Uh,
Thank you, sir.
Most of your topic has been covered by Panikar, sir,
Yes,
but
that's why I want to say that. Yes.
we still to
Yeah,
stand to learn from your talk, sir. Thank you.
right. Yeah, actually, you're right, Dr. Bichandani. Dr. Parikar spoke more on pioglitazone rather than sulfonylurea. So I don't have to talk much, but still, as a part of formality, the pioglitazone revisited broader implications of metabolic health. What you see in your slide is the AP review. AP stands for Advanced Pharmacological Preferences Evidences, which is published from Washington, D.C. It's about 3 years ago. It talks about a rethink of pioglitazone. That's what it says. And you said low dose pioglitazone, not what we thought of. I think Dr. Panikar thought it much earlier. And this publication looked at 2023 about low dose pioglitazone. I think we should give a round of applause to Dr. Panikar for having thought it earlier. So if you don't see this slide, I think Dr. Veermani showed these slides of the ICMR data in 2023. And what it shows is we have 101 million patients, which accounts about 11% of patients of diabetes. And what is disturbing, Dr. Veermani mentioned, is about 136 millions of pre-diabetes. And why it's important? Because this is the pre-diabetic will become diabetic future. And therefore, you cannot curtail or you can contain the epidemic unless you reduce the incidence of pre-diabetes. So that is the problem of pre-diabetes in this country. Now, if you look at the subgroup of diabetes population that we have in this country, it's an inspired trial, which is the first time in India looking at 19,000 patients. What it tells you is that we have the 40% of the patients have insulin resistance as the important factor. And this is called IROD, which is the insulin resistance of obese diabetes. And there's a combined insulin resistance and deficiency both together, which accounts almost to 40% of the population of the diabetics in this country. And if you look at this metabolic dysfunction syndrome, which has the insulin resistance and beta cell dysfunction as the core defect in patients of diabetes, and which is driven by poor lifestyle and ultimately results into obesity or pre-obesity, we have the MASLD and dyslipidemia. And therefore, we need to treat this particular problem of insulin resistance and beta cell dysfunction. This slide was shown by Dr. Panikar, which says when you need treat patients of hyperglycemia, of course, we need to control the patient's glycemia because we need to improve the microvascular complication. And the macrovascular complications are driven by metabolic dysfunction syndrome, which is basically nothing but insulin resistance and obesity and hyperinsulinemia and hypertension. And therefore, when you look at pioglitazone, it has action on multiple sites. It has action on adipose tissue, the skeletal muscle, the liver, and the macrophage. The activity on the adipose tissue improves the uptake of fat into the adipose tissue by improving the insulin sensitivity of the adipose tissue. It also reduces serum lipids and also reduces free fatty acids in the circulation. It also improves the uptake of free fatty acids into the muscle, and the hepatic glucose production goes down significantly. And what is the most important action is on the macrophage of M2 variety, which is the anti-inflammatory macrophage. And what it does, it reduces cytokines, reduces chemokines, improves the cholesterol efflux from the macrophage, and therefore reduces the burden of atherosclerosis and have the improvement of the adhesion molecule. And therefore, if you look at these studies, the most important first is the A1C effect or efficacy of a drug. When you compare with metformin over 12 months of time in 1,100 patients, you see the A1C reduction is quite good, up to 1.5%. The other study, which is the duration 4 trial, which looked at the comparison between pioglitazone, metformin, exenatide, and sitagliptin, you see the effect of the reduction of the A1C to tune of 1.6%. Looking at the hypoglycemia as a problem of treatment of diabetes, the metformin and pioglitazone have a least incidence of hypoglycemia unless it is combined with sulfonylurea or insulin. This is a very important study which looked at the insulin sensitivity of the muscle by pioglitazone. We know that the metformin does not have much insulin sensitivity impact on the muscle because the muscles do not contain the organic cation transporters. Therefore, it does not have much action on the muscle. What is the background noise? So, if you look at the insulin mediated uptake of the glucose in the muscles, especially in the metformin therapy, whether it's an open trial or double blind randomized controlled trial, the uptake is just 11%. But if you look at the glitazones, the open study looked at 36%, And if you look at the double blind trial, it is 34%. So it's very effective in the insulin mediated glucose uptake, which is called M value in the muscles, telling you thereby that the insulin resistance is significantly reduced by pioglitazone, but not by metformin. If you look at the lipid levels of these patients, either in proactive Chicago or Periscope, you see that the good reduction of triglycerides with increased amount of HTLA. What is background noise? Okay, okay. It also reduces the urinary albumin creatinine ratio. If we look at studies of various trial studies with pioglitazone and metformin, you can see the significant reduction of the albuminuria. We know that albuminuria suggests that the patient has endothelial dysfunction and also tells us the progression of the renal impairment. And we look at all these studies with metformin, pioglitazone, metformin sulfonylureas, or metformin sulfonylurea, you see the reduction of the albuminuria is quite significant in patients who have been taking pioglitazone, suggesting that it improves the endothelial dysfunction in these patients. We have some cardiovascular outcome trials which looked at these proactive Chicago Periscope and IRIS trial. Most of them is said by Dr. Panikar, but I'll just repeat it. And the first is the proactive trial, which looked at about 4,000 patients, 4,000 plus patients. And the entire idea is to see the primary composite endpoint, which was the non-fatal myocardial infarction, non-fatal stroke, and also included people who required revascularization. And because of that category, it did not meet the primary endpoint, and therefore the secondary endpoints were exploratory. So we have the recurrent stroke reduced by 47%, recurrent MI reduced by 28%, the acute coronary syndrome reduced by 37%, and the permanent insulin was reduced by 53%. If you look at this study, which has the pioglitazone and the cardiovascular outcome, this is the meta-analysis looking at 12,000 patients, and this is how you see what is the impact on the MACE events. And there's various studies which says that the point estimate is before the line of the unity, which says the pioglitazone is associated with the reduced risk of MACE in people with insulin resistance and pre-diabetes and diabetes. If you look very carefully, the I-square value at the bottom is 0. That means there is no heterogeneity in this study, and therefore this study is very reliable. This is the BMJ Open Diabetes Research Care, looked at people from United Kingdom, about 56,000 patients who were given pioglitazone versus 56,000 who did not receive pioglitazone. And if you look at the outcomes, the cardiovascular, all complications, whether it's a complication in terms of diabetes complications, ketoacidosis, hyperosmolar keto, any of these complications, and if you carefully see the myocardial infarction, congestive heart failure, were less in people who took pioglitazone compared to who did not. To the right of your screen, you see the Kaplan-Meier curve, which shows the mortality of the pool data, and you see those who took pioglitazone has a better survival compared to those who did not take pioglitazone. In other words, the cardiovascular benefit are profound value when you use this molecule. This is the Chicago trial, which is compared along glimepiride, looking at the intima media thickness of the carotid vessels, which is the surrogate marker of atherosclerosis. And what you see here, that the reduction of the IMT in patients who receive PIO compared to those who receive glimepiride, and a similar study which was done in the IVUS study, which is looking at the intracoronary volume of the atheroma, which shows a reduction significantly of the volume of the atheromatosis in patients who received pioglitazone. The IRIS study, which patient Dr. Panikar spoke about, is about 3,000 plus patients who had insulin resistance without diabetes, and these patients had either suffered from a stroke or they had ischemic attacks, transient ischemic attacks, were randomized to receive pioglitazone versus placebo for a period of 5 years. And what you see in these patients, that a recurrent stroke was reduced by 24%, myocardial infarction reduced by 24%, and a new onset diabetes was reduced by 52%. So this is the impact of this molecule when used in patients who have insulin resistance syndrome. So also you see that the central obesity, which is because of visceral obesity, and you can see this MRI picture after 16 weeks treatment of pioglitazone in the patient who's 59 years old, and you see the visceral obesity has decreased from 140 centimeters to 105, and his weight is gained, but his hemoglobin A1C dropped from 7.3 to 6.5%, which suggests that there's an improvement of insulin sensitization, but there is shifting of the fat from the visceral to subcutaneous area. The NFLD muscle area is an area of great importance to all of us, which is the most important cause of renal transplant in the Western countries. And we know that it is driven primarily by insulin resistance. And we have this lipid steal hypothesis, which is how the pioglitazone work in these patients tries to shift all the lipids into the adipose tissue, and therefore by reducing insulin resistance, it also reduces fibrosis, lipid concentration, and inflammation, and therefore has a lot of benefit in patients of NAFLD. Now, here's the data from the 2022, the American Association of Clinical Endocrinologists and the American Association of Study of Liver Disease, which gives us guidelines of the NAFLD, which divides patients into low risk, intermediate, high risk based on their FIFO and in the LSM score. And all those, whether it's a low risk or intermediate risk or a high risk, all these patients are benefited by pioglitazone therapy because basically this is the drug which tends to remove the fat out of the liver and therefore controls the patient's fatty liver disease. And this is the Indian data, which looked at about 150 patients of type 2 diabetes with NAFLD, and they were given pioglitazone for a period of 6 months. At the end of 6 months, they looked at the enzymes, the AST, ALT, which dropped significantly. It also showed reduction in the LSM after using this drug, suggesting that this drug is valuable in patients of NAFLD. Now, there are some auxiliary benefits as well that you get. As I told you, the meta-analysis of 30 patients showed there reduces recurrent strokes. It shows reversal of blood vessel disease. It stabilizes the fatty deposits. And very important is it's adjunct to SSRI, major depression. You can treat these drugs with the depression also, and the number you to treat for depression is just 6, which is very effective because it improves the improvement. It has got early response and has a good remission rate when you use this drug in patient with depression. Also, we use a lot of patients are now being given the second generation antipsychotic drugs like olanzapine or quetiapine, and these drugs get development of obesity and diabetes because of drugs. And here you have seen that the irritability, lethargy, and stereotypy is quite significantly reduced when you use the glitazones. And the psoriasis also is improved when you give this drug, and there's enough data to say that the psoriasis also improves. So we have the science of balancing risk and the benefit. We have seen all the benefits. There are some adverse reactions which we're worried about. One is a weight gain, which requires a good lifestyle modification or a co-prescription with SGLT2 or GLP-1, which can mitigate the weight gain. Heart failure, of course, in the NYHA classification 3 and 4, you should not use this molecule because of the inherent risk of a heart failure. The bone fracture, especially, should be very careful in using this in women who are postmenopausal, and therefore there is a possibility of the bone fracture in these patients, which you should be very careful. The bladder cancer is a big issue. There's a retrospective observation studies and prosperous studies also. The proactive study had 14 cases reported. But what is important, what is not been told, that few of these patients already had bladder cancer, and some of the patients had relatives having bladder cancer. So therefore, the number of patients are 14, which is 0.5%, versus the control arm, which is just 6 cases, which is 0.2%. But a word of caution, those who have history of bladder cancer should not be given, and those you keep on estimating hematuria at these patients where there is any evidence of a bladder cancer. This is the update of 2025 American Diabetic Association, which says the PIO is recommended as a secondary or add-on therapy for patients of type 2 diabetes, especially those who are requiring additional glycemic control with the coexisting metabolic abnormalities, especially NAFLD. So therefore, friends, we have a drug which has got protection in multiple organs, and that's what we believe in giving protection to these patients. We have 40% reduction in the secondary stroke. We have benefit in the intima media thickness in the carotid vessels. We have reduction of 28% in reinfarction in patients. We have reduction in the albuminuria quite significantly, reduction in myocardial infarction, and also protection to the liver. So we have this drug which works at the multiple sites, giving these benefits. That's why I think Ralph DiFranzo has written this article in Diabetes UK saying pioglitazone is inexpensive, very effective in reducing A1C, no evidence of bladder cancer, plenty of evidence for cardiovascular benefit. So therefore, this benefit is shown in lipid metabolism, in the glucose metabolism, in inflammation, cardiovascular disease, in cancer disease, and in the virus influenza also there's some evidence that influence can go down by using these drugs. With that, I conclude my talk. Thank you very much.